Can I please call this meeting to order, and can I welcome members of the public and also invited guests and members of the public, as I say, both here and those watching the webcast, to today's meeting of the Health Committee. Our main topic of discussion is young-onset dementia, and we encourage anyone taking part in the discussion on social media to use the hashtags #AssemblyHealth. First, we have a few items of formal business to go through before we get to our main work for this afternoon. So, are there any apologies for absence?
Thank you, Chair. We've received apologies for absence from Assembly Member Twycross and Assembly Member Bob.
Brilliant. Thank you. Can I ask members to note the list of officers set out in item number 2 of the agenda, and also ask if members have any other interest to declare? No? Okay, thank you. Can we confirm the minutes of the meeting of the committee held on the 11th of January 2018 to be signed by me as to the true record?
Agreed.
Thank you. Can we note the completed and outstanding actions arising from our previous meetings?
Agreed.
Okay. No. And this brings us to the main item of work for this afternoon, the discussion on young-onset dementia in London. First of all, let me please welcome Hazel Robinson and also Diane Campbell, residents of London, who are going to tell us their life story of having the diagnosis of young-onset dementia. So this is an opportunity for us to listen from you of the issues that you have faced, and also to tell us what you think is relevant. And I think we've been giving the questions already for you to comment on some of the issues. So we will just listen to what you have to say. First, perhaps maybe Hazel. You want to start off, Hazel?
Okay. Actually, I'll read out what this heading is. I'm not sure who made these headings at the moment, do you know? The organisers. Yeah. Right, good. Okay. How difficult was it for you to get a diagnosis? For me, diagnosis was not a particular problem. I have a good GP, and I live in near-ish to Charing Cross Hospital, where they have a good set-up for people with dementia. Well, that's a bit of an exaggeration, but they certainly, I was signposted.
Can you just sit forward so you speak into the mic?
Oh, is that right?
Yeah, that's a mic, so it'll pick up your voice a bit more clearly.
It's quite difficult to sit. I'm rather short, you see. I'm terribly sorry. I really am quite short. You can't make them come forward, can you, these? No. Okay, don't worry.
Never mind.
All right, I'll do my best. Okay, sorry.
No, that's all right.
That's much better.
Right, I'll start shouting. How difficult was it for you to get your diagnosis? Diagnosis was not a problem, really, because I was helped by my GPs. I had a good sort of through line to Charing Cross Hospital, which and I had lots of tests, some of which I failed, which was terribly upsetting, of course, because that was the point. Can you do that? I used to be able to do that. No, I can't do that, which is very difficult. Anyway, so I was diagnosed with Alzheimer's disease. I can't remember when now. I think it's more than 2 years now. It seems like forever, actually. It seems timeless. That's what's happened, because I lost my job. It's just everything is gone. No, not everything. It's not true that everything's gone, but it felt like that at the beginning. So then I was diagnosed, and the first really shocking news was that there were no services whatsoever in Brent at that point, except there's a local hospital in the very north of the borough. I mean, this is a long, I used to work there, and it's quite a long, it's difficult to get from almost anywhere, especially now, to actually get there for a start. And and there's nothing in the south at all until Ashford Place opened up, and I can't remember when that was actually, when it started having its dementia things you don't remember either. Sorry, I don't know why I'm looking at you.
No, that's all right.
We're both as good as each
I
other.
think if you want me to jump in, I think we will open it on, I think it's 2016.
Really?
Yeah.
Gosh, so that's quite a long time that we didn't have anything. Yeah. Yeah. So there is. I mean, I think the main. The trouble is, it's very difficult to. The main thing. Oh, it's the wrong way. Sorry.
Don't worry, don't worry.
I'm not usually quite this floaty. Oh yes. When I was actually, just before, when I was first diagnosed, there was a nurse, I can't remember, who's also called Hazel, which was remarkable because there are very few people called Hazel. And she worked in the south of Brent, the very south Kilburn. And she came to see me, I think, twice or three times, and it was such a relief. Then she left because suddenly Brent lost all its funding. And that was just when it was pretty dire, I can tell you, because just as I needed the services, they were gone. It was really grim. But fortunately, I don't remember it very clearly because of my Alzheimer's. But I do remember the shock of it. It was just, I couldn't believe it. That there was absolutely nothing. I thought this can't be happening. But it was true. So it says here that I now have to travel out of the borough to access support from professionals. But I think
that was Diane. That was Diane.
Oh, right. Sorry, that's you. This is your bit. Oh, do you want to say something about it?
No, you
This
finish.
bit?
No, you finish.
Well,
then
okay.
Yeah, so what is your experience
Oh,
with
okay.
dementia services in London?
Do these work well for you? Who wrote this? Do you know? Did I? I'm sure I didn't. Sorry.
There's feedback from you and Diane.
Oh, okay. So
about
it's
your
been
experiences. of
okay.
dementia
Our
services in
experiences of dementia services in London. Yes. Well, getting support after diagnosis, which I can assure you is essential because I didn't have any. So I can tell you that if you don't have any, it is absolutely crushing. It took me a long time to get, well, in Ashford Place eventually. I don't know when that started, but anyway. But it's very important, really, because if you don't get any support, you just crumble, and your mental capacity, it might still be residual, but you've got to be using it, really, to keep as much as you can with the programme, if you see what I mean. Then it says learning strategies and coping methods to manage symptoms of dementia. I don't know what that means. Which occupational therapist would that be? That's Diane's. Okay, so perhaps we should have done this more, because we had in a way, quite different experiences, because you were getting help before the crash of the funding, and I didn't. So it's not. We haven't got quite the same history in relation to the condition. Right. So that's Diane's doing learning strategies. Ooh, what's that?
I think it's the microphone.
Sorry?
It's the microphone. It gets quite sensitive when you're close.
Doesn't matter.
Don't worry, we understand.
We do it all the time, so don't worry.
It needs some therapy. The next thing is families needing support, to show them how to help their relatives stay as independent as possible for as long as possible. That's about carers or caring. And it's certainly a very, very important issue. It's not one that I'm involved in directly, or in fact, well, I'm not sure. Anyway, I don't have a carer, and I never have, which is partly why I'm so bolshy, because I have to speak for myself. but it's true that there are a lot of problems I've observed it's very hard for relatives, I think. It's very hard. My mum had dementia, so I sympathise with them. But it's very, very difficult to get it right, because you might say there isn't anything exactly right, but there's a lot wrong, and you can do a lot of things wrong. So the next thing says, in order to address lack of services in Brent, the community is developing peer support networks. Well, this is this is our little support network. It's been good, actually. Yeah, it really has made a huge difference from nothing. I mean, that's great, you know, but, I mean, there's no funding, as far as I know. Is there any funding? No. Maybe that makes it better in a way, I don't quite know. But so we turn up if we can, don't we?
For the peer support.
For the peer
there is
support
funding,
day.
from the CCG.
Yeah,
Brent
that's
CCG,
right.
yeah.
The CCG saved us a bit. That's once a week, isn't it?
Yeah.
And for a couple of hours, is it? Can't remember.
Yeah.
A couple of hours, yeah.
And it's just a chance for people to share their experiences.
Do we do that in the peer support program? Do we? Oh, sorry. I mean, the stress of this has made me more flaky.
Can I say something to the board?
Please.
Because I think Hazel, the environment that Hazel come in today, I think maybe that slowed down Hazel a little bit. So
Yes,
I think that's why
That's so
Hazel
understandable.
is a little bit struggling today. So she's fine.
Am I?
Yeah, you're fine.
Oh, you are, don't worry.
She's fine.
What do you, could you just clarify for me? Is it because it's so alien, this environment?
No, it's not.
What was it then?
It's just because the environment that you come around and it's open.
Oh,
So-
this.
so-
I used to
so
give
that's-
speech. I
that's
should
why,
be sitting.
yeah,
You
that's
know
why.
what? If I stood
There's a
up,
bit-
I'd probably be fine. Because I used to give talks all the time. I used to teach people things, you know, and I know how to do that. But
Yeah,
anyway, that's
that's
not
why
a
she's a bit
discussion.
Well, Hazel, we know that. Hi. Thank you very much for making comment. Maybe you want Diana to help you at this stage. We can all help. It's all right for Diana to speak.
Yeah,
if she wants
otherwise
to.
I'll ramble on forever.
No. It's very valuable what you're saying to us.
I think this point, Hazel, because I know that. So.
Done
Just
that.
find the bit about transport, so
Ah.
difficult getting around the city.
That's
yeah?
the
Would
point.
you like to?
Sorry, waving my finger.
Go
But
on
that's
then.
the thing.
Tell us
that-
about transport. Yes.
Oh,
Yeah. Yeah. So
That-
about the difficulty
that's
on the tube.
That's the worst thing, because I get lost, and I like to go to the galleries and paint with my friends and things. I will not paint, draw anyway. And it is just, I cannot do it by myself now, because, well, I mean I do, but I get lost all the time because my orientation is going, and that is really, really difficult, because going out and doing stuff, going to see art, I mean, you know, I'm part of a little art group, and it's really, really undermining not to be able to do those things with a bit of support, or even, well, I know we can't have a taxi card, because that's I know we can't, or Brent can't, I don't know who gets it, but
So with the taxi cards, they're usually the criteria is mobility issues.
yeah, that's right. So we're not eligible, even though I kept thinking, well, I get lost, can't I be eligible? I know. So yeah, so that's a big issue for me, and actually it's not only me, because not every, you know, it's quite an issue for everybody in the project, actually, except I don't think there's anybody who lives around the corner. No.
Yeah, everyone lives a bus away.
Yeah. I better stop, hadn't I?
Well, Hazel, thank you very much for making the effort and for coming in. We know it's incredibly difficult for you to come. But let's see what Dan has to say.
Yes.
And then you may want to come in later on and say something else. That's fine, okay?
Thank
I
you.
also want to welcome the students from the pupils from Collington Primary School in Tower Hamlets. So it's good of you to come. We're looking into dementia in London, particularly dementia affecting the early onset dementia. So this is what we're discussing this afternoon. This is the Health Committee. And you are very welcome to stay as long as you want to. And the member you must decide the member for Tower Hamlet. So you're lucky to have him here. Great, thank you. So Dan, back to you. Welcome to the Health Committee, and also perhaps you can ask the same question I think on your sheet.
Okay. How many questions on my sheet you want me to answer?
Start from the beginning and go through all the ones you have on your sheet.
Okay. Well, the first one is, what support did people normally receive after they're diagnosed? I diagnosed in 2013, and as Asa said, the support wasn't there, but as a younger person who has the diagnosis, I was fortunate to get an occupational therapist that worked with me, and she did give me her time for a year, which was good for me. You don't normally get that. People don't normally get occupational therapists to work with them. And so I was lucky that, the memory service and my GP could provide that. She worked with me for a year, so maybe that's why I'm so articulate in doing most of the things that people with dementia can do, so I'm grateful for that. After that, it was like chaos, because I think most of the people that they would want to said help, like some of them don't really have a clue who said they're dementia nurse. And so where do you go from there? They come into your house and basically they're telling you to do things and they're not helping you. So say for instance, a month I'm down and I had to go to my GP, and my GP referred me to one of them. The only thing they bring is papers for me to go and refer myself, which I think is just ridiculous. The funding in Brent, because I think when I had the diagnosis, there was nothing in Brent. I live in Brent 26 years, and I think it was a shambles, because totally relying on my occupational therapist, she had to take me out of Brent down into Westminster to get looked after at the memory service. And it's a shame that, it's two boroughs, one is better than one, to get the help that you needed. I stayed down in Westminster to get the help that I needed, and how to learn how to manage myself, and just to go about my daily life, because I live by myself. But I think when that project finished down in Westminster, I still have to go back to Brent. And what did I tell Brent? I just go ballistic. And I didn't care who I go ballistic with. They just needed to do something, because it's a shame that, Brent is so diverse, and it's a big population in Brent, and something happened to a young person, and, you don't get the help. So, yeah, we get some projects set up, because I open my big mouth, right, and they listen. And as Hazel said, the project that I get set up, that's where she is, and she get the help. Other people in the company.
It's not quite as good as it used to be.
Well, because it's a new project, we work at it, and so we reach a bit far in it, where we get funding from the CCG, coincide with the council. We lost our dementia nurse in the south. There's nobody now in the south of Brent, south of Ashford Close. Sorry, but there are nurses right at the top. Yeah, but then I will. The project get people, the young-onset people, out of their house, and that's the reason why we set up that project, is to get people out of their house. which is a day out for them, to get them to, you know, come in the community and just teach them how they can manage themselves. For me, it's a godsend project because I give back, because that's what I'm there for, as a person with the young-onset. I set up another project, so we have 2 projects running. I think they could do better with the funding within our boroughs, because you got people just like me who get the diagnosis, needed help with the occupational therapists. And I think if there was enough funding there to do that, for the GPs to say, okay, we will give that for the occupational therapists to help people, especially younger people with it, then I think that would be good.
Yeah.
The next thing is the experience. He said, what is your experience of dementia service in London? Which I think I just covered. There is not a lot.
There's not a lot in Brent, but there are
Brent.
in some other areas.
Yeah. There is not a lot in Brent, and I would love Brent to get a lot of support to do that and set up the projects. So, you know, people with that can get good, especially with early onset, because I think, you know, we needed that. We needed the support. And I think, you know, when I just diagnosed and started out to campaign for younger people to get, you know, because as far as I'm concerned, before I diagnosed, you would hear it's only older people get, you know, this condition. And every time you go, they dig the heel in to say, oh, it's just older people. And so I get so frustrated, I have to stand up and say, look, it's not all about older people. I'm really sorry, because I am in that circle. As a young person, I diagnosed when I was in my 40s. And you can tell me that your experience is different from mine. Because a person with the condition, I will communicate with them better than I am communicated with my doctor or my counsel.
Absolutely.
So I think that we all need to pull our socks up and just get it right. I think it's full time that we come together and just show that, you know what, we're living longer and anything can happen. It just take one just a sec for anything to go wrong. Nobody knows when it comes, but
you mean it might
you're gonna
be
avoid
you.
it. You can avoid it.
Can I just add one thing? Sorry to interrupt, but I don't know if I wrote that.
Both you and Diane made this
Oh,
suggestion.
okay.
Yeah.
That some boroughs have a lot of support with, for example, services from the Alzheimer's Society, which is fantastic. The Alzheimer's Society is very good. We don't. I don't think it would be fair to say. I mean,
There isn't a service in Brent.
and there isn't this thing called Dementia UK. I've never heard of it. So-
Diane, you know about Dementia UK, don't you?
Yeah. So I all these bits I know about because I'm on the board.
Which board is that?
The Dementia UK service.
I didn't know that.
So I am on the board of it to work with most of the nurses. Because I think sometimes when dementia nurses go into people with the condition homes, I think the questions that they come up to ask people is so ridiculous. It is so ridiculous. And so we're trying to get an easier way and a better question for them to go in family home and ask these questions and what the carers can do. Because I think most of the times what they intend to do is speak to the carers and not the person with the condition. And so I'm sure that you might heard of it a lot, that, you know, these nurses, they go in to the family home and they ask all these carers these questions, and the person with the condition is sitting there. You know, you can ask them, and they will tell you how they feel. They will tell you what's going on. And so what we do on the board is try to get the questions that nurses can go in and speak to the person with the condition and hear their point of view. Because it's not, everything is done taken away. It's not every day the memory just boom over the hill. There are times it settle down. And there are times that it really, really go up. So, you know, you got a balance. You can speak to them.
Up? I missed that bit, sorry.
The memory.
Up or down? I mean, sorry. Do you mean it gets worse? Okay. Yeah.
She's saying that some days it's good and some days it's bad.
Yeah.
It's variable.
Yes.
Yeah.
Yes. Does he take sugar comes to mind. Did you ever hear that on the radio?
Okay, so my next question was the challenge of people facing dementia visiting in London. Okay. Hazel touch about that with the traveling thing. I get lost, which is once, and I hope it never happen again, because I tell myself I hope it doesn't.
Only
I
once.
went to.
She's amazing.
I went to Elephant and Castle, which is somewhere I normally go to. There's a health shop there, and I normally go there. But I think the day when I went, I think they change up everything, where they build a station or something like that. And so, totally, I just get lost. And I couldn't remember where I was going, and that was the hardest bit for me. And I asked people where it was going, but I couldn't remember the road or anything. And luckily, I don't know, there was a godsend, my phone rang, and it was my cousin. And so I normally tell her where I'm going in Shepherd's Bush, and I think we went there once, so she literally know where. And she said, "Where are you?" And I goes, "I'm in Elephant and Castle, but I don't know where I am." And she said, "Oh, do you go into the urban shop?" I go, "Yeah, but I don't know the road." And she said, "Okay, stay where you are." And she go online, Google it, and she said, "Okay, this is the place." And I was at a shop. So I could just say to the shop man, "Here's my phone, my cousin's on the phone." And the man would just go. So these are the difficulties that a lot of people face with the condition. I'm on another project with the Alzheimer's, the Tree Nation, and yesterday we had a meeting with the health green paper, and it's the same thing they talk about. You know, about the traveling around in London and the difficulties and all those little things that they are worried about. You know, because if it's not a taxi picking them up, how do they get around in London? What would we do to make London look dementia friendly? What would it look like?
Yeah.
And so my question to you guys, what do you think, you know, London 2020 would look like dementia friendly? So that's one of my kind of big question, because I really don't want to get lost again traveling on public transportation. Some of the stations, they're very good, that you can just ask a question and they take you. Victoria is one of them. Victoria Station is one of them, because I went on there to go somewhere and I asked, and the lady simply take me to my bus. And I think that was really good. Otherwise, I would get lost again, because it's so big and there is no signs. So, yeah, what is it that you're going to do for us?
This is what we are here to look into, what we can do for you.
Okay, my next question is, well, it's the same thing I just covered the transport bit. But there's another thing that I found out with London transportation. I travel on the buses a lot. And it's ridiculous, these bus drivers. I know passengers can be very annoying. I may be one of them, but I think the drivers are so cheeky. And I wonder if they get enough training. Because that is something that we kind of the charity that we set up in Brent, we work on a lot with the Transport for London. We come across those things that people said they wanted to go on the bus. But I think the bus is designed to go down for the driver to put it down. And for crying out loud, they wouldn't. And the other day, there was a lady. I was at the bus stop. The lady was at the bus stop, a little lady. And the bus came and stopped. And the lady, she couldn't, just like Aza couldn't sit up in this chair because it's so low, the lady could not get on the bus. And I goes, driver, just lower down the bus because I can't go on it because it was so high. And you know what he said? I shouldn't tell him what to do.
Sack him.
I should not tell him what to do. And I was furious. And I said, it only take a second for you to put it down and let us get on the bus. And I'm sure they train you for that. And he was so mad with me. He just said, don't tell me how to do my job. And of course, I'm not telling you how to do your job. I'm just asking for help. So these are the things that we, not only people with memory problem, but people with disability face. And I think, it's just ridiculous. I may be ranting, as Aza said, but I'm here to give my opinion. And I'm really going to give it, because I think if 2020 is coming up and you want 2020 to look like a dementia, England overall, because it's not only London people has dementia, but overall in the UK, then I think we really have to work on it and pull our socks up to make sure we get it right.
Yep.
Okay, my next one is, how dementia friendly do you think London is? Oh my God, don't get me started, because it's not dementia friendly, I swear. So I'm going to pass that.
Oh, go on. From 0 to 10.
No, I'm not going to say anything about it. I'm going to pass it.
Would you want to, one of you make the suggestion, this one, that everyone in London with the diagnosis?
Oh, okay, this is a new one. Some boroughs have a lot of support from the Alzheimer's, etc. Some of us don't. Brent, poor Brent. Everyone in London with the diagnosis should have a minimum level of support, wherever they live. That would be nice. Very expensive, though, of course. Be good, though.
Well,
buddy system, was it? Where are those other children gone? We could get that. So, yeah.
And so I think that's me. For the time being, I think I kind of cover.
Dan and Hazel, look, thank you very much for making your contribution. Please stay around. I mean, you may be something you want to add later on. You can do that. We're now going to turn to and welcome first the other panel members of the panel here. First, I want to welcome Sabrina Gentuo, who's the Engagement and Participation Officer for the Alzheimer Society, and then Professor Sebastian Crutch, Professorial Research Associate for Dementia Research Centre at the University College London. Welcome. Dr. Jeremy Isaacs, Deputy Clinical Director of Dementia Clinical Networks, NHS England. Laura Cook, Quality and Improvement Manager for Dementia Clinical Network, NHS England, London region. And also Francis McAndrew, Diversity and Inclusion Lead from the Transport for London. All of you welcome to this session. And you have had the opportunity to listen to two real-life cases in London and their experiences. And so we will explore some of the issues that they raised. First of all, let me go towards Sabrina. How typical the experiences we've heard about from Hazel and Diane, how typical are these examples of other young dementia sufferers in London?
I think the examples you heard are very typical. A lot of people struggle with similar things, such as getting around and the anxiety that comes with that. And Hazel and Diane both mentioned about getting lost in different places, but even on a familiar route, we know that things change quite rapidly on our transport system, and somewhere that is very familiar to you, you always take the same route. Suddenly having to figure out an alternate route, that can be very troubling for somebody with dementia. Similarly, what they said about services being different in different areas, that is also true. For young people, younger people with dementia, we have, I think, 3 commissioned services across London. And then there's also a growing network of peer support and community-based projects. But that the information out there about specific projects for younger people isn't as good as it could be. So it can be a struggle for people to find something that's going to be relevant for them. Whereas they may find general dementia information and go to a general dementia group, but then be in a room with people who they have potentially nothing in common with, or potentially at a much later stage of the condition, which can also be quite scary for people, really. I think also some of the issues that Hazel mentioned right at the beginning, when she said when she first got her diagnosis, she felt like everything had been taken away from her, whereas a younger person would be having a generally normal life, as we would consider it. They could be working and they could have a family, all of those things, and then suddenly just having a diagnosis kind of puts into question those things, and the supports that they have to maintain those things isn't necessarily available from the typical dementia services, because they're used to working with older people. So that is why it is really important to have tailored support and information for younger people.
Professor Crutch, how do you think the challenges faced by the young dementia diagnosis patient compared to the elderly one, please?
I mean, I think there are many similarities and many differences. We've heard of some of the practical differences. If you are working, if you've got a mortgage to pay, if you've got kids at home, those are different challenges sometimes to those being faced by older people with dementia. But of course, the challenges to one's personal identity, one's role in society, the potential disconnection from friends as people step away, as we still are challenging it and gradually changing perceptions of the dementias. But I think still there is, I think a lot of people do experience the sort of stepping away, or people not being quite sure how to deal with them, and forgetting that you're still a person, you're living, and the dementia is just one part, and sometimes still, unfortunately, the diagnosis can cast a shadow over many parts of life, which it really needn't do. We need to recognise the challenges that people face, but it shouldn't be sort of subsume the whole person. I think one of the key things that we are interested in, particularly in our centre, is working and trying to support people who have rarer forms of dementia, which are more common in the younger age group, not exclusively, but and I think that is not only because we work with people with specific rarer diagnoses, but because those people point up the fact that dementia isn't just about memory for anybody with any diagnosis, even so-called typical Alzheimer's disease. Yes, there are problems with episodic memory, but there are also potentially problems with language and with vision, with decision-making, but also many things that are spared, and people continue to focus on what's lost. And I think, sadly, so many of these services fail to pick up on making use of what people want to do, their continued passions, their continued desire to be people with a today and a tomorrow, not just a yesterday, not continue harking back to what people did do, but thinking about, well, given your interests and the challenges you face at this particular step in your journey, what is it you want to be doing, and how is it we can support you to be doing that? Diagnosis doesn't have to just be about everything you're going to lose.
You talk about the rare forms of early onset dementia. What are those rare forms?
So there are, as we know, there are many different causes of dementia, so different diseases. But even if you take a common cause, like Alzheimer's disease, it can express itself in different ways in different people. So yes, the most common presentation of Alzheimer's disease, even in younger people, is the memory-led form. But for example, I work with a group of people where the Alzheimer's disease, the plaques and tangles amongst the within and between the cells, affects the back of the brain. So these are people presenting in their 40s, 50s and early 60s who have visual problems. Their memory for day-to-day events and their insight is very good, but these are people who have a dementia diagnosis, but actually in the early stages their needs and the support challenges they face are much more akin to someone with eyesight problems, even though there's a brain sight problems, than someone with so-called later onset typical Alzheimer's disease. There are other people who have the so-called frontotemporal dementias, which affect the more anterior parts of the brain, so affecting changes in how people converse and interact with other people, and language issues, either difficulties producing or understanding language. And those are the folk who, in the younger onset people, who have the experience, for example, of getting onto the bus, and actually they need to hold a card explaining they have a language form of dementia, because the typical reaction they get from people is actually that they're drunk, because they're slurring their words. And of course, it's nothing to do with that. It's a neurological condition. So I think just recognising that there are these rare dementias, but that for everybody there are these different needs, different strengths and weaknesses, and considering it as a profile of challenges and also continued abilities which can be drawn upon.
And this is an open question to anyone who wants to come in. To what extent is the young onset dementia stigmatised, and how does this affect those people living with this condition? Dr. Isaacs?
It's a large question. I think that it's worth reflecting that people are developing an illness at a stage of life when they're expecting to be well, and living among a community of similarly aged people, most of whom will also be well, and there's a feeling of being isolated in that, living in that situation. And also, I think some of the things that have been said very eloquently about how cognitive impairment can be a hidden disability, because people don't necessarily have all the hallmarks of physical illness, but nevertheless are struggling. I think one of the other things that's worth reflecting on, in addition to what's been commented already, is the way in which young onset dementia plays out for families and the effects it has on family members who will become carers often. And this might be spouses, it might be elderly parents who resume caring for what's now a middle-aged son or daughter. It may be children who are teenagers who get drawn, or people in their early 20s who are just starting out in life who get drawn into caring roles unexpectedly. So there's a whole sort of network of people, if you like, who are affected by a diagnosis of this type. And because young onset dementia is relatively uncommon, we can talk about the epidemiology in a minute, what we know about it, often there aren't that many other people nearby who are going through a similar experience, and so people can feel very isolated for that reason as well.
Okay, thank you. This is so interesting. What do we know about the prevalence of the young onset dementia? And do we know approximately how many people in London are affected?
So if you look at GP records and who on their GP records has a diagnosis of dementia that's under 65, it's about 2,000 people in London. But we need to remember that this doesn't include people that have diagnosis of dementia when they were, let's say, in their 60s, but now they are 66. That wouldn't include those people. Also people that have young onset dementia and haven't actually received a diagnosis yet, and also those people who have received a diagnosis but for whatever reason it's not been given the correct code on the GP practice. So at the moment across London it's about 2,000 people. If you look at research data, and this is research data that's quite old, it was done in 2003, it would say that from the age range of 30 to 64 you'd expect for 100,000 people, 54 people to have young onset dementia. So roughly in London that would equate to 2,300. I think it's important to think we don't know about how this prevalence will increase. There isn't any data on this, but I think we can presume that in London, as we have a growing population, and we'd expect a growing population of that bracket between 30 to 64 years old, we should expect the numbers to rise.
Thank you. You mentioned the age 66. Is that the time you stop calling it young set?
Yeah, so once it's 65 and above, it's dementia or older dementia, but in general terms, people from 64 and under, it's young onset dementia.
Okay, thank you.
It might be worth pointing out that this is an arbitrary distinction.
No, I take that,
Yeah.
yes. No, it's interesting because there has to be a cut-off point somewhere. Is there any particular group more likely to suffer with this? Have you found any?
So what we know from the epidemiological studies, which are now quite out of date, is that one of the major modifiable risk factors that contributes towards young onset dementia is alcohol misuse. So alcohol-related dementia contributes a fair proportion of the total. And cerebrovascular disease is also a fair contribution of the total, not quite as much as it is in older people, but it's still a significant proportion. This is people who've had a stroke, or people who've had lots of mini strokes that may not necessarily show up as major strokes, but over time accumulate and cause vascular damage to the brain. And we know that vascular risk is modifiable to a certain extent. So important messages around what's good for your heart is good for your brain apply equally to people with young onset dementia as they do to older people.
Thank you. Earlier, Sabrina, you said, and I think the ladies have said as well, that it's different in different boroughs. Just in your opinion, I accept that, which borough in London gets this right the best? Where is a shining beacon to any of you that we should be looking at if we're looking at doing any report on this, that you really think that they've got it right?
Well, I think Diane has something to say. I can hear some whispering.
Oh, it's a whispering. I think
it's got more money. Westminster's did have lots of services. I don't know if it still does.
Well, I was actually going to say Merton.
Merton?
Yes.
Wow.
Because there is a dementia hub in Merton, and they also have a specialist young onset support group there as well. But that dementia hub has a broad diversity of activities for people of all ages, where you will find something that is going to be relevant for you. And it promotes the independence and the interests of the members. They also have a very active co-production group, which brings together people with dementia and their carers to look at potentially local issues that are affecting them being able to live well and what changes they could make. I think that they are a good example about how you can provide services for people with young onset dementia, but also empower them to make a difference and be able to live the lives they want to live.
Thank you. Because sometimes it isn't the money, it's how things are applied, and that's far more important to us looking, and best practice is so essential. Do you then find, going on from that mental stimulation helps to hold back the dementia or not? Do you? Anybody want to answer that?
There are a range of evidence-based interventions for dementia, and they apply across the age range. There's no treatment that has specifically been evidenced in young onset dementia as opposed to late onset dementia. And as we've heard, young onset dementia is many types of dementia, and so different treatments will apply in different people. The access to treatment, be that pharmacological treatment or non-pharmacological treatment, needs to be offered on an equal basis, irrespective of age, because the evidence base is across the age range.
Okay, thank you.
You wish? Okay. This is some questions to all of you first, and then specifically to you, Sabrina. The Mayor's got proposals to looking to focus on key areas, namely transport, business, housing, planning, as well as health and care. Are these the right areas to focus on for people with young onset dementia? Is there anything missing? And what would make the most immediate difference to quality of life for people living with young onset dementia in London? So if we can start off with you, Sabrina.
I think the areas that you've identified are really important, and I think they're also reflective of what people living with the condition say are important to them. I think the one other thing that I would add to that as well is around employment, which is particularly relevant to this age group. So there are a number of people when they get the diagnosis who are either need help to stay in employment, and the businesses they work for need some support to know what kind of adaptations they might need to make to allow that person to continue to do their job. But equally, there are also people who can't cope doing the job that they need to do anymore. But some of the assessment processes for finding out what people are able to do don't actually recognise cognitive impairments in the same way as physical impairments, which puts people with dementia at a disadvantage. And I think that's similar to what both Hazel and Diane were saying in terms of assessment for things like door-to-door services.
For example, you're not eligible if you only have a cognitive impairment. So that's really difficult because getting transport around London, not just for me, but it's difficult navigating London, but I've done it all my adult life until recently, and now I just get lost. Well, I don't always get lost, and that's huge, you know. I don't know quite what to suggest about it, but I think it's something about recognising that it's not, I don't know what we could do as a, you know, it needs some imaginative thinking, because it's not only about money, it's about how we relate to each other and who's available to help us out in particular situations. And sometimes at the tube stations, I think it was Pimlico station, they were so helpful because it doesn't have very good signage, tube stations don't. And then I went back to my usual home and I went on to whatever it was, I can't remember which one it was now, Baker Street or something, and I was just completely confused because it's just old-fashioned. I mean, Pimlico's more recent, so it's got better signage. I mean, that wouldn't really cost a fortune to update some of those old signage things and that kind of thing. It's not going to cost an absolute fortune, but it's imagination and will. I'll help, she says. I'll do anything. Oh, God, it's so frustrating. It's just so frustrating. Yeah.
For me to say something.
Go on.
Is it about the transport?
Well, different areas. Transport is just one area, but there's business, retail housing, planning, healthcare.
I used to, I think about a year now, they employed me at the St. Mary's Hospital. And so it was really epic with them because I think we got a dementia team at St. Mary's Hospital. And so I used to go in and help to do some training when they have the training day with some staff, nurses or doctors, wherever. And so I said to them that instead of me volunteering, why don't you pay me? And so that was kind of a bit of a, you know.
Yeah.
And so
challenge.
I said, it's the same thing that when I volunteer, I do. And it's the same thing, if you paid me, I'm going to do. So why not pay me? And so HR kind of bit fight, why should they pay me? Well, why should I volunteer? And so I explained to the team that if you need me to come in and do and talk about what's going on with me for other people, the nurses or the doctors, to understand and how to work with people who come in the hospital that mean admitted in there, not by the condition, but have the condition and how to work with them, then get me in there. And so it was a struggle for HR to get me in there, but eventually they decided to get me in there, they pay me. It is a work that it's not a workload, but maybe once a month or maybe once in 3 months, I do go in there to do the training with the staffs, with the dementia team. And for me, I was happy with that because I look forward to go in and they can ask me questions. just like how you asked me a question, and how do I cope with my daily life, ethic, or whatever. So I think that, people who has a condition, they're still valuable to the community. But, it's when, everything has been taken away from them. That's when the problem is. And God forbid, any one of you there have the condition. I'm sure you wouldn't be happy for them to say, okay, we don't want you anymore. Because it's something that you do for years. And I'm sure you maybe don't manage all the paperwork, but there is something there that you can teach. You can say, okay, I need to get the place that I worked for 10 years, 15 years together to teach them about what I'm going through and how they can, go out there and help other people. So everybody is really useful in their own way. With the transport, I would love, for you to really to get it right with the bus. I'm not going to knock the train, because when you go to the stations, they give you help as long as you ask. So I'm happy with the train. It's just the bus is a bleed nose, but I'm happy with the train.
So one thing I'd add to your list is the cultural sector. I think, as we've heard a lot from everything that's been said so far, obviously dementia conditions, the diseases caused dementia are healthcare problems, but many of the issues people face are social problems. And people live with many different forms of dementia. Obviously, they're hugely variables, but often people are living with these conditions for 10 to 20 years. So I think the things that we can do to support people to live with these conditions are really important. And we, for example, recently have had the opportunity to run the rare dementia support groups in a museum setting, the Wellcome Collection in London. And obviously that's a very privileged, nice space, but it makes a real difference to the quality of the meeting. And we're in the cultural. It's difficult to imagine any place which has more cultural resource than this city, and yet matching up. And yet frequently people are saying, "Oh, we would have a support group, or we would be able to get you if we had somewhere to meet." And dementia support group meetings and peer-to-peer meetings, they don't need to happen in a horrible, dry clinical space with wipeable surfaces and those things. They need to be happening in the sort of warm, inviting spaces that are sat in London, which during the day are frequently grossly underused. So linking up those two sectors for me is vital.
Great cafes in the Wellcome Collection, for example.
There are indeed.
I mean, getting there, you see, for me, is quite tricky.
Absolutely.
Now. But when I'm there, I'm happy as anything.
Absolutely. So transport's definitely. A lot of these places are well set up for dealing with people with different mobility needs and other things.
I don't know what to do about it.
Can we move on to you, Jeremy?
Sorry.
Yeah, I mean, I would say that there's a challenge to the research community to repeat some of the epidemiology around the prevalence of young onset dementia in London. The data we've got is over 15 years old, and London population has changed quite a bit in that time. And the number of people living who are aged between 30 to 64, which is the key group at risk that we're talking about here, is increasing. From the existing data, we haven't got evidence from that about how important factors such as ethnicity or socioeconomic status impact on dementia risk, young onset dementia risk. And I think that some up-to-date epidemiological studies would be very, very helpful for the NHS in terms of planning services and looking forward to making sure that the service matches the demand.
Could you just mention pollution somewhere, because I think, I'm not asking for a big discussion, but I do think it's quite relevant, probably, in some areas of high pollution. Sorry, I'm interrupting again. I'll shut up now.
I would say there's something about messaging. So it was great that you received a timely diagnosis, but we know people with young onset dementia can often take twice as long for a diagnosis. And part of this is people often present with non-memory symptoms first, which we've talked a bit about today, like personality changes. But everyone thinks dementia, they think memory. People go to memory clinics. So there's something about the Mayor championing that message that dementia isn't just about memory.
Francis, apart from transport, because we've got a series of questions on transport, is there anything specific you want to say?
No, I think I'll stick to the transport bit.
All right, well, we'll put all the questions to you. And finally, Chair, through you, can I ask you, Linda, sorry, Sabrina, because Linda's not here, that how can training and awareness initiatives, including Dementia Friends, be made more widely inclusive of people with young onset dementia?
Sorry, could you repeat that?
How can training and awareness initiatives, including Dementia Friends, be made more widely inclusive of people with young onset dementia?
I think Dementia Friends, which I don't know if everybody knows about Dementia Friends, it's a short introduction to the 5 things we think everyone needs to know about dementia, and it can be delivered within 45 minutes. And it's rolled out across communities and businesses. And I think that really touches on the point that everybody was talking about in terms of changing perceptions about dementia. Because one of the key messages is that it's not about memory, and the other key message is it's not just about age. So promoting that and also working more with people like Diane and Hazel to deliver the message is really key. So I know that as an organisation, in the next phase of rolling out our plan to make society more dementia friendly, we want to be including people affected by the condition in putting that message out, and having more opportunities where people see people living with dementia that don't look like the stereotype they may have in their head. That will be really important in changing those ideas.
Any specific?
I was just going to say there are resources increasingly available. So, for example, prompted by members of our support group, we made a free online course a couple of years ago called The Many Faces of Dementia, which is exactly that. It's high quality video footage of people living with different types of dementia, talking about their experiences with interviews from experts and clinicians and so forth. And that's free. It can be done online anywhere on a computer, anytime, by anybody. And 50,000 people have done it so far. But you know, it's that sort of getting the voices of people like Diane, because once you've met someone like Diane, you're not going to forget, or Hazel, you're not going to forget the experience. You're going to be faster to jump to the conclusion that dementia is a possibility here when you're seeing a young person presenting with these range of problems.
Thank you. I'm going to talk to you now about health and care services, and I particularly direct my questions towards Sebastian, you, and Jeremy, you. What role do primary care services, and particularly GPs, have in identifying and supporting people with young onset dementia, and how are they doing?
Thank you. So what we would like GPs to do is to identify people appropriately as early as possible and refer them on to a memory service or another appropriate service to get a diagnosis. There are resources available to help GPs with this, so the Young Dementia Network, which is a collaboration of professionals and people from the voluntary sector, has produced some guidance for GPs. I've got a version of it here which I'm happy to share with you, which has some helpful clinical guidance on how to pick up the telltale signs of young onset dementia. Also to be aware that memory symptoms in young people are not that rare actually, and the majority of people, young people with memory symptoms, don't have dementia, and it can be difficult to tell the difference. But what we want is for memory services, so diagnostic services and GPs, to work collaboratively so that GPs can get advice and refer, but can have a dynamic response back. And so we encourage memory services to think of ways of communicating with GPs, advice and support to make sure that people who don't have dementia but have memory symptoms get diverted into the right pathway, and then people who do have dementia can quickly go through the system to a diagnosis. If we look at dementia as a whole across London, the diagnosis rate has gone up significantly. So in London now, about 70% of people who, of the total number of people we estimate to have dementia have a diagnosis. And that has gone up. It's almost doubled over the last 6 or 7 years. So that's a fantastic result. And what's good for dementia as a whole, in terms of how people come through the system, will be also good for younger people. In terms of speed of getting a diagnosis, we know from various research cohorts and also from anecdotal experience that younger people do take longer to get a diagnosis, and there are all sorts of complex reasons behind that, some of them to do with a lack of awareness in the system that, as we've heard, non-memory symptoms can be the lead symptom of dementia, so changes in language function, changes in personality, and these are often not interpreted by patients, by families and health professionals early enough as being a sign of dementia. But one of the things that the NHS is trying to do in general at the moment is to encourage memory services to speed up the process of getting a diagnosis, and NHS England produced guidance last year that asks all memory services in the country to increase the number of people who get a diagnosis within 6 weeks of referral. And that's not just a label of a clinical condition, it's also starting treatment as well. And again, that applies across the age range, but that will also be good for younger people. So we think we have evidence that actually in many ways the situation is improving, more people are getting diagnosed, we're asking the system to be more responsive and get people through more quickly, but there are challenges because dementia is a difficult thing to diagnose a lot of the time. It's not a simple diagnosis. People need access to specialist care. We need GPs to have access to some resources, and some of those are now being produced. So there are still challenges, but we are optimistic about the direction of travel.
Did you want to say anything else, Sebastian?
Yeah, I would second everything that's been said, and just to say that, of course, people don't always present to their GP, particularly when they have these other symptoms. So to take one example, we've been working with the College of Optometrists recently to develop training for optometrists, ophthalmologists, and high street opticians, who may be the people who you'd first go to if you had a vision problem, because we'd all assume it was our eyes, not our brain. So I think training up those other specialties and pushing out and not expecting the GPs to do everything. I think these initiatives are absolutely great. That is where the majority of people will go. But we need to all step up and say that if we see someone where we think something doesn't quite ring true, just that increasing that willingness to refer on.
Jeremy, how well equipped are London's dementia services to meet the current and future demands?
So dementia service is obviously a very broad category of service, because there are services that are designed to offer a diagnosis and start people on treatment. There are specialist services, for example, neurological services that see a minority of people who have particular additional diagnostic or treatment requirements. And then there are a whole range of services which are commissioned, some of which are NHS, some of which are social care, some of which are voluntary sector, that provide support after a diagnosis. So it's not one thing, there's a whole range of, a whole spectrum of services. Laura, do you want to discuss the issue of memory services?
So memory services, there are a variation in London. There's a variation in waiting time, and part of the role of the clinical network is to help reduce that variation. And we are working with the memory services to help them reduce their waiting times through streamlining their pathway. So as we said before, it's not always about money. There are different ways of streamlining pathways. So, for example, having a very lean triage process to referrals. And I think it's important to think about integration. So it's about the memory services either having someone that's got a special interest in young onset dementia within their service, or working closely with their local neurologist. It's not always about additional services, it's about working more closely together. And actually, for the clinicians, does it feel integrated? Do they feel comfortable? Do they know who to pick up the phone to and call? And I think thinking beyond diagnosis, one of the key things is this thought of care navigators. So NHS England released a implementation guide recently, and apart from the memory service waiting time, the other key thing was that everyone with a diagnosis of dementia should have a named navigator. So this is someone that you would go to call on for advice. They know the local system, they know what services are available, and they can help you to do what you want to do to live well. So yes, some people really enjoy going to dementia cafes, but someone, like you said, you'd like to go to your gallery. So it's about supporting people to do what they want to do, and we are working with the commissioners to help them look at different models about how they can implement that. But I think we've got to think about, with care coordinators and navigators, for young onset dementia, these navigators do need to have that education and the skills to know where it's different for younger people to older people. So, for example, we've talked about employment today.
If I may just add one point about continuity of service, we hear time and time again about great ideas, great projects, but which are short interventions, people having 4 weeks of this or 8 weeks of that and then nothing, or getting a great really good workup at diagnosis and receiving a ream full of advice about information and this about that and advice and future legal things. And it's about recognising that these are conditions people live with for a very long time. People want to know they want to know information at the right time. So when you first got your diagnosis, that's probably not the time you want to be necessarily thinking about long-term care planning or financial needs. It will vary, of course, from person to person, but having continuity of service, and lots of people would prefer to have a service that, where they can touch in and out 2 or 3 times a year for 10 years than these short, sharp interventions, which look very good for statistics because you can say a lot of people have been through the service, but actually knowing that there will be someone you can ask about a question you find, rather than having had a bit of help and then thinking, I don't know who to go with, this is a critical issue.
May I just ask a question? I'm sorry. When you say a service, what service are you talking about? Because I don't feel I have a service at all.
No, absolutely.
I mean, I have a GP.
So I think I prefer to talk in terms of people. So you had both talked about, for example, having people, an occupational therapist or a nurse who was there for a little while and then left. And I think the services need to be ongoing enough. Yeah, exactly. Whereas I hear things from support group services where people build relationships, sometimes with professionals, sometimes with other people living with a similar condition, which go on and perpetuate for years and years and years, and they're there for each other right through the journey. And I think we want to see more of that if it's possible.
There isn't a containing structure at the moment. It's not going to work. It's a lovely idea. But at the moment it's so fragmented.
Absolutely.
That's why it's not hanging together. And if you put everything together and we mixed it, well, not mixed it, but I think there'd be a lot more.
So you've put it better than me. So fragmentation is exactly the point I'm trying to say. We need to address not just volume of service, but about saying how do these things connect. And things like the Care Navigator if implemented properly, do have the potential to mean that you have someone who can lead you through and kind of introduce you from one team to the next team to the next team, rather than just feeling like you're constantly having to re-explain your story. That's
a medical model, but I'm thinking also about a social model.
I agree.
Because at the moment it's all by borough.
Yep.
So, I go 100 yards down the road, and my world is different. I mean, I know there's nothing in a way that you can do about that, but I think politically it's tremendously important to integrate our needs, whoever we are, whoever's in need, with, beyond borders, as they say in the, it doesn't, it's really unfair.
I agree.
It's terrible, actually.
I suppose my motivation, if I agree about the need for a social model as well, is our experience from running these rare dementia support groups for people who have these rare conditions. So we now support over 3,000 people across the UK. And the critical thing that people ask for is, I want to meet other people who know what it's like. And that often isn't a professional. It's someone else who's living perhaps at a similar stage or who's been down that road before. And for a lot of people, it doesn't matter whether they're in Gloucester and you're in London. If you can have phone contact, occasional physical meet-up.
You need to meet.
Absolutely.
Sometimes.
But sometimes if you really spread, you can't. And some people would prefer online support or telephone support to nothing.
No. While we're at it, I'm just going to make one more complaint. But I was diagnosed just at the point where I was trying to learn how to do online, and I can't. I've tried, I do. If somebody does it to me, I'm not too bad. I mean, online, I don't know quite what you call it, but if they send me, I cannot do it. It's so frustrating. And I'm not that stupid.
And that's about choice as well. People shouldn't be made to feel they have to connect in a certain way. We were just hearing about examples of people being given, how do you want to connect with other people? Some people do want to do it that way, but not everyone.
No, of course. No, good for them.
I mean, I allowed this to carry on because this is my next question. That we have issues about diagnosis, right? But it's once you make the diagnosis, what happens then, right, to patients? And once, what support structures are there available for them after diagnosis, to the GPs, to the network? I'm a GP some of the time of my day, and I have this issue, right, that I've been very good at making the diagnosis, right, or helping get the diagnosis done. But then the support structures to keep this patient in the community just fizzle away, right? And Hazel has described it to you very eloquently, okay? So that's the challenge. And how are we addressing those challenges? What happens post-diagnosis?
So I think the point about care coordination is well made, and there's an expectation that everyone with a diagnosis of dementia has access to a named care coordinator. and assuming that people
Do they exist, Jeremy, in the system, the care coordinators?
There's different models of it across London, and there's areas,
So this whole variation of it across London.
variation again. So you can pick out. So, for example, Bexley commissioned the Alzheimer Society to do their care coordinator model. For example, in Islington, it's run through the memory service. So there's different ways of doing it. In Kingston, they run it in primary care with a GP and a nurse who both have special interest in dementia. But I think the key thing is the role of the coordinator, not who provides that role. So it's about navigating the system. It's about making sure you've got access to healthcare, social care services when you need it, and supporting you to live as well as you can with your dementia, supporting care planning, and then when appropriate, advanced care planning. So I think we need to think about the role of the coordinator, not necessarily who provides that role.
Well, I accept that there's various forms, but is there someone in every single CCG who's responsible for this? I mean, if I was going to say to Harrow, for example, there'd be someone there commissioned as a care coordinator for dementia services.
So there are commissioners, generally the mental health commissioners do the dementia commissioning. It is an expectation of NHS England that everyone has a named coordinator. It's not happening across London at the moment. There is huge variation.
Okay.
Easy to say, not easy to swallow.
Yeah.
That's terrible.
Yeah.
Okay.
I mean,
Susan?
nobody's ever told me that before. But it makes sense. But it doesn't, you know.
Right, we're on to Francis now. Poor Francis, who has sat there listening.
Sorry.
Francis could have run out the room because Francis is from TfL, Transport for London. So you've heard it eloquently put. Obviously, there's an issue here. So the question: how well is TfL equipped to assist people with young onset dementia?
Thank you, Chair. And thank you, Diane and Hazel, for reminding me why I took this job 4 weeks ago.
That's a very good way of putting it. That's just 4 weeks ago.
Because I had the honour and privilege of helping write the Mayor's Diversity and Inclusion Strategy last year, which will soon be launched, which is why some of you might remember meeting me at the Oversight Committee. But we spent a summer talking to people across London about what really matters. And I was struck by how important transport is to people's quality of life, happiness, getting to work. And I now have the privilege of doing this work at TfL. So how equipped are we? I suppose I wanted to think more about the social model. So I think it would be it'd be wrong to suggest that we have got our act together in terms of young onset dementia. But what we do have a role to do, and I think the way we tackle issues like this is to look at the barriers. What are the barriers on the public transport system that we can remove? And when we get it right for a group with young onset dementia, we hopefully get it right for others. And those barriers that we've been, and actually also looking at how do we do better end-to-end journeys? Because any journey is only as good as the worst part. So as you say, if you get the buses drivers trained up and then you get the signage well, if we suddenly move the bus stop that day, then the journey is really bad. And we know that for the research that we have shows that the fear of a bad journey is really important. People won't travel. So we've got lots going on, and I thought I'd like to share some of that with you, just to kind of give you some of the ideas of what we do to remove some of those barriers to make transport more inclusive. And they're all under this kind of principle of inclusive design, which is how do you build something that actually everybody can use together in an inclusive way, and it's by removing the barriers. We haven't got it all right, and I know there's an awful lot to do, and I'm kind of, that's why I'm there. I have a job now, and that's things like better audio-visual information. So we need the both. For those with the hearing impairments, we need kind of all kinds of different ways of telling people about their buses, about their trains, about reminders that the stop's coming up. We get feedback sometimes that those announcements are annoying, but when we talk to groups who experience neurodiversity, dementia, disability, they tell us that they are incredibly important. So it's my job to amplify that voice and make sure that those that say those announcements are annoying don't kind of win. So yeah, we really need to keep going with the audiovisual announcements. Our commitment to keeping stations staffed while services are operating, as well as now running turn up and go. So it's not just that you have to book assistance, you actually can turn up and go, which is absolutely a fundamental right to travel. Clear and accessible and intuitive signage really helps everybody get around the network, but I'm taken by your point that it's really good in places, especially the newer stations. Go to Baker Street or Paddington.
Paddington. Oh, don't.
Yeah, I know.
It's my hell.
Yeah, so there are some where it's still really, really tricky, and we've got a lot to do. There is TfL runs a travel mentoring service that not everyone's aware of. It supports people to make independent journeys. Door-to-door services totally take the point about they are focused on mobility, not on dementia. So I've got a little list of things to go back and think about. Thank you. But we have recently removed the requirement for anyone using those dial-a-ride services to have somebody with them. There used to be a kind of a mentality that you would need a carer. But there's a recognition now that that's not necessarily true. Priority seating, we've got the new please offer me a badge. Please offer me a badge. Please offer me a seat badge. Especially to help those, a badge wouldn't be much use, would it? To help those with invisible impairments. So that's really important. We need to get better, and we are doing a lot around accessible information, but also information about access. So where is the network step-free? But how do we give you information not just online, because we recognise the percentage of people that are not online and digitally excluded. There's a whole team of people now doing local engagement to get information such as that about the travel support card system. So this is a system where people can carry this card that you can give to others if you're lost and you're having a difficult journey, and it tells them who maybe to call, how to help you, and that there's something you need to tell them about. Maybe you're having a difficult day that day. So but we need to get that information to the right people. So we're doing lots of local engagement, going out to Alzheimer's groups, carers groups. And I would just sort of finish saying that we know that if we look at the inclusive design work and that social model, the biggest barrier that we know exists is attitude. So we could build a wonderful network, but if the person that you meet that day hasn't got the awareness and the attitude right, then the whole system breaks down. So with that in mind, we are training our staff in disability equality training, and at the heart of that is disabled people running the training with us. But also we've got funding and a fantastic member of staff who sat behind me called Amy Edgar, who's going to be rolling out dementia-friendly training across Transport for London network. And she's also going to now pinch, because we've just found out a bit, some of the case studies from Sebastian, and use those as well to share people's lived experience of dementia. So lots being done, but lots more to do.
Well, I'm very happy that the young lady, forgive me, I've forgotten her name already. Amy. Heard Diane's comments, because sometimes it's just kindness on behalf of drivers, whether you're with yourself with a problem or a disabled person, to be treated in an unkind way. It needs to be sorted out straight away. You've given us a sample of lots of things, so you're clearly aware that TfL has got a problem, so that's great. Can we have some timelines here, because these people are living this all the time? How quickly do you hope to put in some of these ideas?
All of those things already happen. So all of the things that I was talking about there happen. I think the role that I've taken on is about consistency and application. So you want to know that that happens across the board.
It's evident that there is help, because it often isn't.
And that the right people know they can ask for help and how to get help. So there is more work to do. We've just got a new team. I would love to get back to you if you would be interested with a plan that we're putting together.
Please, I'm sure we all would.
Yeah. So we had our first away day yesterday, and we're creating a plan that will naturally support the work of the Mayor's Diversity and Inclusion Strategy and the Mayor's Transport Strategy, and tell you how we will put all this into practice at TfL.
Okay,
so I'm really happy to come back.
Certainly that card is a good idea.
Yeah.
But it needs to get out to the people that need to be using
Absolutely.
it, because that is a good idea. And then obviously constant training to make sure that if they present a card, that all the staff know what to do with it.
Yeah.
I also I'm sorry to be so verbose, but I've been thinking about these things for ages.
Of course.
And it's like, bleh. You know, I was kind of, oh, somebody might listen to me. Look. Taxi cards. You know that you're only eligible for taxi cards if you have a physical impairment.
Yes.
Have I already said that today? Forgive me.
No, that's all right.
This is the trouble with dementia. It's very embarrassing.
You have, and thank you for saying it again, and I've written it down.
It's really, really important because it cuts off a whole way of moving around.
Yep. Well, Francis has taken note
Thank
of that,
you.
as have we.
Okay, Umesh, over to you.
Okay, last set of questions. The Mayor is planning to hold the dementia-friendly summit, London summit, sometime in the spring. Now, obviously, people with young onset dementia are an important group. In what way can this particular group be involved in developing the Mayor's plans? And this question is to all of you, as well as what's one specific thing would you ask of the Mayor to ensure that dementia-friendly London is fully inclusive of people with young onset dementia? So how can young onset dementia people be involved in developing the Mayor's plan, but also one specific thing that you'd like to see the Mayor doing regarding this particular group? So if you can start off with you, Francis, for a change, and Mr. Sabrina.
I think that you said, what would a dementia-friendly city look like? I think I don't know, but I know what it would
young
feel.
people.
I know what it would, with young onset dementia. I think it's what it would feel like. And I think people would feel respected and understood, and they would be met by people who understand what they're going through and know how to help. And I think the Mayor can do an awful lot to raise awareness of the need for the dementia-friendly training and to promote the inclusive design agenda through the London Plan and through all the Mayor's transport strategy.
I think it's really important that there's events like this where we're listening to people that are actually living with young onset dementia. We can talk as much as we like about clinicians, what we think, but it's about talking to people who are actually living with that experience. I think that's really important to share that. But also from a health perspective, I'd be really keen for the Mayor to help with some of our messaging. So, for example, around the care coordinators, having the Mayor champion that he wants to see everybody with a young onset dementia have a care coordinator. You know, we are supporting services and we're getting there, but not everybody does have. But having the Mayor back that message as well would be extremely useful.
Yeah, I'll second that. I think we've also heard from very eloquently about the value of peer support. I guess there's a challenge that people living with dementia would want to be integrated into the wider community, but also can benefit from creating their own communities of support and exchange. And there are many ways in which they can be supported. It's not necessarily something that sits exclusively within the health system. It can be supported from a range of different angles.
So how can people be involved? By talking to them. So when in the planning stage, or when before the plan is finalised, we host meetings. Jeremy hosts meetings. There are lots of groups and opportunities to come and talk to people and get their voice, because people have different views. So that's how people can be involved early. And I guess in terms of the one thing to ensure is in the plan, I'd slightly subvert the question and just say I'd like to see the plan feature things that have actually been achieved already during the plan, during the development of the plan. Some of these, we can't wait on all these things, and we've heard even today, even about taxi cards, we could take a couple of examples of things that could actually be actioned in the next few months with the kind of collective will of this sort of group.
Yes. Okay. Well, as a person with young onset, I do get involved, and I have my views and I say my piece, and I think coming here today, it's the first time I come in this building, but what I can see is not dementia friendly. And so it would be nice if you could get, me back, Hazel back, and show you what we mean about dementia-friendly building. And so, in case other people come, then what? For instance, the toilet. It's ridiculous because it's just a tiny bit of sign on it, and somebody have to show me around the corner where it is. And first of all, that's not dementia-friendly. I went in there, in one of the cubic, you can't even move, and the light is not working, and so yeah, there's so much. It's a big, nice building, but yeah.
Can I just say, in defence of the building, the public toilets they're not actually proper. They're not proper. Oh, you're talking about the public ones?
Downstairs.
Okay.
When we came in
I thought
and the cafeteria is
Oh,
there.
right, okay.
So that would be a start.
Yeah, okay.
To tell the mayor, if you're going to work with people with dementia and get advice, then you need to start here to say, okay, and then we're going to go outside. And so, yeah.
Okay, fair enough.
That's a very fair point.
Yeah.
Thank you.
Hazel?
Sorry, what do you want me to do?
It's only if you wanted to join in, but
Oh, yes.
Apart from your taxi cards, is there anything else we can try to help?
Sorry. Well, it's difficult because because I've been a very awkward, as you can tell, I've been a sort of awkward person, always complaining and trying to make something happen. And without any funding, almost. I mean, there's virtually no funding at all in Brent. And that is the biggest problem, I'm afraid. We cannot do the impossible. I can't, you can't, nobody can. Why can't we get some more funding for our needs in Brent? I mean, I know it's nobody's fault exactly, but it's somebody should give us a hand, for goodness sake.
Brent has just been declared a borough of culture, right, yesterday.
Great.
And they're getting £1.3 million, so maybe some of it can go and look after. So we are giving the money to Brent.
Right.
Brent is getting some money.
Right to Councillor Butt.
what was that?
Brent was getting some money.
Can I get that in writing? Thank you, black and white.
Let us come and help you spend it.
We struggle with me setting up a project on my own. We, Sabrina, Amanda, they know, and literally because we try to make sure that people eat healthy when they come to that project, we get the space at the church. And so one other thing, we had a church bus that a pastor kindly let us use, but it's gone, it's kaput, it's not working. So we have to, they have to put money out of the church fund to go into, to get the brand van to go and pick up the people. And the bad weather like this, like Monday, the weather was so bad. But for me, it's not about me. It's not about me anymore. It's about those people that needed my help. And, we ring them up to make sure that they're coming in the weather. But our pastor could get the van with the funding, the money from our church pocket, and pay to go and drive and pick them up and come to the project. So I think, I struggle with that. I literally struggle with that, because the way we have to get things going is we cook fresh food. And I beg and I open my mouth to go in the community to say, we need help. And so, it would be nice, as you said, Brent is going to get money, but make sure that the right people get the funding to do the work within the community and to give back to the community. Because, as I said, it's not about me. It's about me getting those people in the area to get a day out for them, and to get the van to go and pick them up and bring them back home when they finish. We've done so many things on that day, on a Monday. I'm there from 8 o'clock, and 4 o'clock we finish clean up and everything. And so, at times they would like to sit down and watch a movie, but they can't because the van has to go back by 1:30 to pick up school children. So, we have to change the time to say, bring them in 10:30. And so they can get to do the fun, communicate with other people there, and enjoy themselves, watch a movie, have their lunch, have their 3 meal. Sometimes we have to rush them because they can't have their dessert, what they love so much, because the van has got to take them back for 1:30. So if you're going to do the funding, make sure it goes within the right place.
Places. not just one place.
Sabrina, any final thoughts?
Yes, I agree that we need to be speaking to more people like Diane and Hazel, and I think one of the very encouraging things is when we got the invite to come here today, we contacted the groups that we work with and other groups that we are associated with, and the response was very positive. People were really pleased to be asked, to have the opportunity to be heard, because I think a lot of people living with this condition, particularly young onset, feel like they're on their own with it, and that they're not being supported or heard. And they all have a lot to give and a lot of experiences to share. So to continue that conversation is vital. And I think two things that I would ask, if I may, is the 5 different areas that we looked at. They're all important, but they all also need to talk to each other. So it's all well and good if we have amazing cultural centres that are open to people with dementia, but if those cultural centres don't know how to support people to get there by knowing all the services that Transport for London are putting in place, then that's not going to be a great experience for the person with dementia. And the second thing I would ask is that it's great talking to people to formalise the plan, but actually let's also work with people to make sure that how we're putting it into practice is going to be delivering the results that they really need.
Thanks, Jeff.
Yes.
Would you permit me to make one final contribution? So speaking more in a personal capacity in my day-to-day job, I'm a clinician working in a neurological department at St George's Hospital in Tooting. And some of the specific issues that I've come across through my dementia practice over the years that apply particularly for younger people. So thinking just about the issue of employment, and often people are diagnosed when they're still in work, and we've heard a little bit about that today. And I think there's a role for the multi-sectoral response to how people can be supported to continue in work in an adapted role following reasonable adjustments, or to change their hours, or to go through an agreed process of retirement. But there should be a range of options available to people, and there's probably a role for employers, for employment advisors, for trades unions, all to be involved in trying to make that process of changing, and if that's what people want, finishing employment as supported and personalised as possible. And the other thing that I've seen is that there are lots of legal issues that can arise for people with who are diagnosed with dementia, and that's at least as much of an issue for younger people as it is for older people. Often people, as I said, as we've discussed, may have responsibility for dependent children or elderly parents or whatever. And often people have difficulty accessing legal advice. Solicitors are not necessarily affordable for everyone, and I think there's an issue of accessibility and equality in terms of how people get legal advice. There was a very interesting project that I found out about at the UK Dementia Congress in Manchester, where the law department at Manchester University has started a sort of dementia law clinic using law students supervised by qualified solicitors to offer free advice for people affected by dementia, either as patients or carers, and helping them with some of the legal issues that arise. And there may be an opportunity, because we've got some great universities and obviously big law firms in London who might similarly be able to contribute towards such an effort.
Great idea, thank you.
Look, thank you very much for your contributions this afternoon. If you think of something you want to say to us, which you think you've forgotten to mention to us, please do write to us. We're still happy to receive evidence and ideas which you have. And may I thank you for coming this afternoon and taking your time up. And can I please finally ask the committee to note the scoping document attached in Appendix 1 of the report? Yep. Yeah? And you delegate authority to me as chair in consultation with the party group lead members to agree any outcome from these discussions. Thank you. Can I ask the committee to please note the Health Committee's report, Supporting Mental Health for All, as attached to Appendix 1? And can we also agree the recommendations that to progress the committee's work programme and to agree to use the next meeting on the 14th of March to question the Mayor's Health Advisor on matters relating to Mayor's health and care agenda?
Definitely.
And can I please note that the next meeting will be taking place on the 14th of March at 10 o'clock in Committee Room 5. Thank you.
Thank you.
GLA Chamber Sound.